Good morning. This is John Bennett, Dr. John Bennett from Miami, Florida. It's morning here in Miami. And in Mumbai, we have Dr. Sagar Abichandani. He's a dentist from Mumbai. He's been having a series of hangouts educating us on occlusion this week. And today, Dr. Sagar is going to talk about occlusion and implant prosthodontics. So welcome, Sagar.
Completely my pleasure, John. Very good morning to people out in the United States. Good afternoon to people in Europe and my fellow countrymen in India and the South Asia continent. A very good evening. So in continuation with the series, we're going to be resuming with occlusion. This time it's going to be on implant restorations. By the time we get this thing set up.
Okay.
Yeah, there we go.
There we go. It's a little bigger. Yeah, that's good.
So just a small recap as to what we've covered in session 1 and session 2. In session 1, we introduced the concept of occlusion. We discussed about the various terminologies that were used, how it is different from an artificial occlusion, what are the different parameters we have to consider when we are taking into account natural occlusion, artificial occlusion. Then we also looked into the different concepts which exist in natural dentition, how it is different from what we aim to achieve in an artificial occlusion. In session 2, we looked at complete dentures, the different troubleshooting and the areas where we encounter problems, different situations, different clinical scenarios. How do we best overcome those atrocities and problems with simple techniques as far as the cuspal anatomy goes, the plane of occlusion goes, inclination of the cuspal morphology goes, the compensating curves go, and we have to blend this between the two extremes, the anterior guidance or the anterior controlling factor and the posterior factor, which is the condylar guidance. Having understood that, today we're going to talk about implant restorations. Implants, we know, have revolutionized the art and science of modern dentistry, giving a new lease of life to the restorative aspects involved in day-to-day practice. Today, implants are choice number 1 for any restorative aspect as far as a missing tooth goes. The clinicians know that, the patients know that too. But what happens is, if we simply go by the technology that implants are available, and we only follow what the herd follows, that is, place implants, it will osseointegrate in 6 months, put any restoration you want, and your job is done. You're wrong. It's then the job begins, because any titanium surface, if it goes inside your bone, will osseointegrate. But what is important is when you load your implant, that is when you get it into function, it's then you have to understand the science. The patient comes to you for replacement of a missing tooth. You give him a bridge or an implant, he wants a tooth back. Okay, so what we have to understand is that the restorative component is of utmost importance. If we are giving an implant, we have to make sure that not only the surgical protocol is taken into consideration, but the restorative aspects also are considered. Otherwise, we encounter a lot of problems, even from an abutment screw loosening, which is the most commonly encountered, to the most severe, which is actually the wobbling of the implant, wherein we have to use a trephine and take it out. We shouldn't reach that stage ever. For implant prosthodontics, we have to understand that it's a ladder. We have to demystify the entire clout to understand step-by-step approach. That we foresee success, we foresee long-term success. If today we aim for success, we have to understand how we are supposed to build on to the success. That should be the key. We have to make sure that there is a minimization of overload. We have to have a proper diagnosis. There is no substitute to proper diagnosis and treatment planning. This is the first stepping stone be it for complete dentures, be it for fixed prosthodontics, be it for implant prosthodontics. If you are not able to diagnose well and formulate an adequate treatment plan, we are playing with fire. Today or tomorrow, we are encountering problems. We need a passive prosthesis which will offer adequate retention and form. The next word is progressive loading. That is, it has to be loaded sequentially. We do understand that there is a concept of immediate loading as well, but progressive loading helps as far as improvisation of the amount and density of the adjacent bone is concerned. And the last point, which itself is the most important point, is development of an occlusal scheme that minimizes the risk factors. We have to understand this. Occlusal scheme is something which you cannot surpass, you cannot bypass, you cannot leave it aside. You have to address this equally. We do understand that there are a lot of inherent differences that exist between the teeth and implants. An implant actually acts as an ankylosed tooth. Okay, there is absolutely no periodontal ligament for an implant. Hence, there are no proprioceptive receptors. We also see that the tooth morphology has got roots in such a way that if there is more amount of stresses, you have multi-rooted teeth. However, for an implant, they are just cylindrical blocks. Okay, we do not have multi-rooted implants. So there are inherent differences that exist, because of which the occlusal scheme also has some differences, which we have to understand, incorporate, and be happy that these are the key success stories which we can build on thereafter. We also have to take into account the kind of forces generated by the patient. There is a differentiation between an adult and a child and a geriatric case, because the forces existed by all three will be different. Similarly, there will be difference in the forces when your natural teeth occlude, your natural teeth opposing a denture occludes, two opposing dentures occlude, denture opposing partial denture occludes, fixed crown and bridges over teeth occlude, and implant restorations occlude. So there is a difference that exists. Now we also have to understand that there are few instances where patient has parafunctional habits, because of which the forces generated are enormous. If we don't take that into account, we are missing out on something as far as longevity of our restorations go. So the aim of occlusion for osseointegrated prosthesis is not just for a prosthodontist like me. It should be the aim of every clinician, every practitioner. We have to direct forces in the long axis of an implant. This is something which we cannot ignore. We also mentioned this as far as complete denture goes, we need axial loading. Same thing will be spoken when we talk about tooth supported restorations for full mouth rehabilitations using two different concepts, which comes in the next session. We also have to make sure that there are minimal lateral forces on the implant. When we talk about minimal lateral forces, we have to make sure that during excursion, when your mandible moves to the left, right, in front, behind, we exert least amount of forces on an implant. If we have to exert these lateral forces, they should be as far anterior in the arch as possible, as far away from the fulcrum. What is the fulcrum in this stage? This is my temporomandibular joint. It should be as far away as possible. And how should the load be? We have to distribute it over as many teeth and implants as possible. Our goal is stress distribution and not stress concentration. The minimal occlusal goals that we are looking for is bilateral simultaneous contact. If it's not bilateral, what we're introducing, premature interferences, which again causes non-axial loading. We do not want any prematurities in the retruded contact position, which is nothing but centric relation. Smooth, even lateral excursive movements with no non-working interferences. There has to be a harmonious movement. We do not want any interference which is going to glide over this harmony. We need equal distribution of occlusal forces, as mentioned earlier. We need freedom from deflective contacts and intercuspation. Intercuspal position is that position when my teeth bite. That's my chewing position. I do not want any deflective contacts, because what happens is it's only then my muscles start to accommodate these deflective contacts. Again, mentioned in session 2 for complete dentures, same concept remains for implant prosthesis too. We do not want any interferences. We do not want any deflective contact. Anterior guidance whenever possible. This, as mentioned earlier again, is a concept wherein it is my anterior controlling factor under my control. The posterior controlling factor or the condylar guidance is not under my control. So what is under my control, I have to make best use of it. We've been talking about making sure that there is no overload that occurs. But what happens if I tend to ignore that and consequently there is a biomechanical overload? It can vary from an early implant failure, early crestal bone loss, intermediate to late implant failure, intermediate to late implant bone loss. In any instance, I do not want failures and bone loss. I do not want that. Screw loosening, uncemented restorations, component fracture, porcelain fracture, prosthesis fracture, peri-implant disease. If any of these things happen, now I realize that I am to be blamed for this. So I wouldn't want to take responsibility for all of these, right? We do not want the patient to come back complaining of these symptoms. You do not want to open the mouth and see these things happening. What we realize is we have taken utmost care as far as the surgical protocol goes. We have taken utmost care to make sure we are giving good primary closure after getting good primary stability. We are taking utmost care to record proper impressions, either at the abutment level or at the impression level. We've taken utmost care to give a passive prosthesis, but we have neglected my overloading factors. In spite of taking care all throughout, I have neglected one step and I land up with complications. So the neglected step can itself be detrimental to your long-term success. Implant protective occlusion, as given by Carl Misch. The complexities in the study of occlusion have set tough challenges for both undergraduate and postgraduate students, and the introduction of osseointegrated implants has further complicated these challenges. The principles of occlusion are applied by dentists for the natural dentition directly to the implant-supported and retained restorations. That's where the problem comes. We do not understand the inherent differences. We do not understand the differences that have to be applied for implant-supported and retained restorations, and we end up with trouble. If we do not know that there's a trouble which is facing us, we do not know how to overcome that too. So what are the overloading factors? An overextended cantilever, parafunctional habits, a large occlusal table, steep cuspal inclinations, poor bone density or quality, or inadequate number of implants. In the subsequent slides, we'll be dealing with each of the factors in detail. Now coming to the non-axial load on the implant function, we've been stressing about axial loading, loads along the long axis, first for the tooth, now for the implant, because this is something which doesn't change. We have to have axial loading because I have to imagine that if my force is acting straight onto the implant, it goes through the implant down to the bone. If there is a force which acts at an angle, for example, the force is acting like this, what will happen is this area bears the brunt of my force, because of which there is increased bone resorption that occurs here. Ideally, if the force is acting straight, the force is distributed all along circumferentially. However, because it acts in this direction, there is stress which acts here, there is resorption that occurs, and it is this area which is bearing the brunt. I don't want that. So what happens is, if it's axial loading, we generally tend to have things acting along the long axis. Okay, there's a small interference. We've lost the slide.
Okay. I can see the effect of non-axial load slide.
Sometimes the antivirus plays a spoil sport. It doesn't know when to start booting.
Okay. We'll get it. Maybe if you repeat this, go back to the form other slide.
Are we good enough?
Let's see. Effective non-axial load on implant function and survival.
Yeah.
That's the one you want?
Yes. Coming to the prima facie of implant protected occlusion, what exactly constitute this sphere of implant protected occlusion? What are the parameters that we have to look into? First is the timing of occlusal contacts. No premature occlusal contacts or interferences. Influence of the surface area. Mutually protected articulation. Implant body angle to the occlusal load. Cusp angle of the crown, which is the cuspal inclination. There's a vertical and the horizontal offset factors, which is the cantilever or the offset distance, the crown height, occlusal contact positions, implant crown contour, protection of the weakest component, and the occlusal materials. The first concept, timing of occlusal contacts. Before we begin with this, there's a small demonstration which I wanted to show. Because this is not a live lecture, it's a webinar, you cannot see me. But still, I will try to make it as simplified as possible using this photograph. Now, if I see this is my natural tooth, if there are forces which act on it because of the resiliency of the periodontal ligament, most of the forces are absorbed by the periodontal ligament. So very little force actually goes through and into the alveolar bone and the bone proper. So if there is load which acts like this, very little force actually goes here. Okay, but what happens is, because periodontal ligament is resilient, there is some amount of depression that occurs into my tooth. Once the force is taken away, the tooth tends to come back. So the depression that happens is approximately 28 micrometers. Okay, now we compare this scenario with that of an implant. My implant doesn't have any periodontal ligament around it. So all the force that acts is taken over by the implant, and if it's axial, goes down to the alveolar bone. Because there is no periodontal ligament, because there is no concept of resiliency of that periodontal ligament, there is no depression that happens of my implant. Because of which, what happens is, if there is a same load which is acting over a tooth and an implant, my tooth gets little depressed, whereas implant remains where it is. So the maximum brunt is borne by the implant. I repeat, if there is a same load acting over a tooth and an implant, because of this factor, the resiliency of the periodontal ligament, my tooth gets depressed in its socket. However, this doesn't get depressed. So maximum brunt of the load is taken over by an implant. Do I want that? No, I don't want that. Why I don't want that is because I want to utilize the concept of the resiliency of the periodontal ligament. So I want the load to be taken by my tooth and not by an implant. How do I actually overcome this? Now that we know that there is a problem, which we didn't know earlier, so we will automatically not be knowing how to avoid this. Now we've identified the problem. Now we should look for solution. The solution for this is itself the step one, timing of occlusal contacts. I want to time my occlusal contacts in such a way that my initial contact is on the tooth, and in heavy biting there is uniform contact. So even if there is some prematurity on the tooth, the initial contact is on the tooth, not on an implant. How do I do this? I ask the patient to gently tap. If you ask the patient to bite, he only knows to bite in one way. You ask the patient to bite lightly, bite heavily, he doesn't know what is biting lightly and heavily. He just knows what is biting. So we ask the patient to tap, gently tap. Use an articulating paper which is thicker, say about 50 microns, and then make sure that you are placing that articulating paper between your restorations. Between your implant restoration and the opposing tooth, in gentle tapping, there should not be any contact on your implant restoration. Should not be any contact. Then I'll ask the patient to bite, chew. In that instance, when the patient is biting, I want uniform contacts between my natural teeth, my implant restorations, and the opposing tooth using a different articulating paper. So now the key is in gentle tapping, I do not have any contact on the implant restoration because it's my natural teeth which take the contacts. And in heavy biting, I am uniformly distributing the contact between my implant restorations, my natural restorations, as well as crown and bridges on teeth. That's why I'm doing occlusal equilibration at step 1, the timing of occlusal contact. What if the canine is missing? Well, that's the question. Let's go one step behind. Why is the canine that important? The canine is my cornerstone of my arch. It is a transition between my anterior teeth and the posterior teeth. If I lose my canine, my arch tends to collapse. It is that important. If I actually go back to my anatomy class, I would see that my canine has got the longest root. Because it has the longest root, it would have a good amount of periodontal ligament, good amount of proprioception. Again, important, proprioception, very important. Another point which I have to see is, where is my canine positioned? It's strategically positioned between my two weak teeth. Which are those two teeth? My lateral teeth of the arch and my first premolar, the weakest posterior tooth present. So canine is very important. What else from an occlusal point of view? We mentioned about canine guided occlusion. So canine is damn important. God forbid if we happen to lose the implant, or to lose the canine, what next? My canine guided occlusion is out of the box. I have to replace a canine ideally with an implant. There is no second thought to it. If I have to give a bridge, my lateral incisor definitely cannot be an abutment tooth. So canine should be the ideal replacement. Second important point which I have to stress is, what will be my occlusal scheme then? If my implant is placed in the area of the missing canine, I have a tooth or a cap over an implant placed in the region of a missing canine. Will I still give a canine guided occlusion? No. I just mentioned about timing of occlusal contacts. If I am only letting my canine guide the occlusion and lateral, I am inducing overloading. I would definitely want that. So from canine guided, in such instances, I have to move to group function. So my adjacent premolars up to the mesiobuccal cusp can participate in my lateral excursion. Again, we have to understand. That's why diagnosis and treatment planning is of such a big magnitude. The smallest mistake can be our biggest enemy. Coming to the bone mechanics and the force direction. All this while we've been stressing about axial loading, axial loading, axial loading. We want the forces to act along the long axis. We also mentioned this earlier. If we have forces acting at an angle, this area that is opposite to that receives the stress concentration. This part starts resorbing. Once this part starts resorbing, you have the microbes infecting this area. Again, we are giving rise to peri-implantitis. Once this area starts going down, we start to lose bone. And mind you, bone loss is irreversible. It's very difficult to get the bone as far as vertical augmentation goes. We cannot afford to lose bone. Very important to understand. What does this picture convey? In many instances, we come across cases where people just place implants where you find the available bone. Is that the way? No, it's not the way. We have to understand that implants are prosthetically driven. Even though it might be placed by a general practitioner, it can be placed by an oral surgeon, a periodontist, anybody, as far as a surgical mandate goes. But they have to think, where will my final prosthesis be? So implants are prosthetically driven. In most of the instances, they find the bone along the palatal side, implants are tilted to that angle. Then you have angled abutments, you have customized abutments beyond the 25-degree acceptable mark. Great, but do we have long-term success? Are there studies which show that 25 years down the line, such things have stayed in the mouth without complications? No. So we have to understand that implants are prosthetically driven. Surgical component, surgical methods can get you the osseointegration, but if your prosthetics are not properly planned, you will encounter failure. Not today, but definitely tomorrow. Coming to the crown cuspal angle, the concept again remains the same as far as complete denture goes. Why? Because we want axial loading. We want the forces to act along the long axis. Now, when they act along the long axis, I have to imagine the cuspal morphology of a tooth. If this is my tooth, what do I see? That this part is my tip, cuspal tip, and I do not want the cuspal tip to act as an interference, because if I want something to act axially, I want it over a flat surface, not a curved surface, not a raised surface. Okay, when I am giving my prosthesis, I have to make sure that for axial loading, I need to have a flat surface. How do I get a flat surface? I have to make sure that my central fossa is flattened. It is flattened to a larger extent. Again, I have to see that if my central fossa, if this is my central fossa, this is a flat surface. In my lateral excursion, that is left or the right side, there is a possibility that my cuspal tips, the cuspal tips or the cuspal inclines, these act as interference, right? So I have to make sure that the cuspal tips are rounded. My cuspal tips are rounded. They are shallow. They are not pointed and round like this. So that's when, again, I'm going to introduce axial loading. What about the marginal ridges? Again, if we see that this is where my implant head is and an abutment over it, my marginal ridges would be here, would be here. Again, if you see, if these points are getting contacted, they are at an angle to my implant body or an abutment overlying it. So these again cause non-axial loading, shear stresses, tensile loading, again going to cause stress concentration. So the three important concepts we have to understand is that we need flattening of the central fossa to a greater extent. We need rounding off of the cuspal tips and the cuspal inclines. More importantly, we also want to make sure that the marginal ridges are not contacted in lateral excursion. Coming to cantilevers and implant protected occlusion. Before we talk about how cantilevers are important, let's understand what the cantilevers are. Cantilevers are the freestanding bridges. That is, if this is my implant, this is my crown, overlying an implant, this is my cantilevered segment. My distal most implant, overlying crown, this is my cantilevered segment. The first question we have to ask ourselves is it practically possible to have one implant for every missing tooth? Yes, no. It's practically not possible. So we have to understand that cantilever segments definitely will be involved. The next question which should actually strike our heads is, what is the acceptable level of cantilevers? We mutually agreed that we have to have cantilevers in many instances. We cannot give away with cantilevers. Because we cannot give away with cantilevers, we have to understand what's the acceptable level of cantilevers. Third question, is the bone quality the same for mandible and maxilla? No. So if the bone quality is not the same, how can we have one benchmark for cantilevers both for the upper and the lower segments? Now, when these three questions strike us, it's only then we will start getting the answers. Once we get the answers, is then we start applying them into our clinical cases. And then we start understanding that few things we have started to get right. And it's those few right things which give us long-term success. Okay. Now, what is the distance of my acceptable cantilever? For example, this is my distal most implant and an implant lying in front of that. I measure this distance. If this is X, multiplying that by 1.5, which will give me 1.5x, that is the acceptable level of cantilever. So if my distance between my distal most implant and the implant lying in front is say about 5, then multiplying that by 1.5, that is 7.5. I can extend my distal most cantilever to the limit of 7.5. It cannot go beyond that, because after that what happens is this will start getting overloading. We'll come to that. Now, I also mentioned about the differentiation that exists between the quality of the bone, the intrinsic bone pattern of the maxilla and the mandible. So if it's 1.5 for the mandible, for the maxilla, the length of acceptable cantilever is 1.2 because of the cancellous nature of the bone. Okay, this is important. Now, just to evaluate a case, this is a patient who would walk down, stating that there is an abutment screw loosening happening probably every 2 months. And what we did was just the shortened arch concept. We made sure that the acceptable length of the cantilever is maintained. After that, the patient was on a 2-year recall, no abutment screw loosening happening. Because we knew what the problem was, we diagnosed the problem, made the corrections, the patient is happy, we are happy. Coming to the crown height and implant protected occlusion. The crown height acts as a vertical offset. What we were discussing about the cuspal ridges was the horizontal offset. We have to understand that a crown also tends to contact in lateral excursions, also tends to contact in centric bite. So the timing of occlusal contacts remains the same. In centric bite, that is when we ask the patient to tap, we do not want contacts onto my implant prosthesis. And when I ask the patient to bite, that is in heavy bite, I have to make sure that there is uniform contact between my implant restorations, my natural teeth, and my tooth supported restorations. The vertical offset factor also plays a role. Coming to the contact positions, again, it was mentioned earlier, if it is acting axially, that is at my widened central fossa, it is axial. Even if you see that I am giving my groove pattern, this again is at a slope, this is again at a slope. So only at this point it is axial. Even if it acts here, 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 it is at an angle. So it is causing tensile stress. Again, if I go far away onto my cusps, that's my cusp tips or my cuspal inclines, it again is non-axial loading. I do not want that. Absolutely no. Implant crown contours. We all believe that we should try to simulate nature. What exists is what we should replicate and duplicate. Perfect. Makes a lot of sense as far as fixed prostheses go for tooth supported restorations. Now we again have to evaluate. The first thing which should strike us is we understand for a maxilla, the bone resorbs upwards and inwards. For a mandible, the bone resorbs outwards and backwards. So a maxilla tends to shorten, mandible tends to widen. A fact which neither I can change nor anybody else can change. We all know that. Now the question which should strike us is, if I have my mandibular set of teeth, the entire complement present, there is a resorption of the maxilla into a tooth which has been missing for a long amount of time, right? Now I'm placing implants for a replication, and I have to make sure that I need a class 1 bite. Is it possible? Yes, very much possible. My lab technician will make a huge crown such that I get good class 1 relation. But then what I am also forgetting is, after fabrication of such a huge crown, there is the placement of the crown which is going to be at an angle to my abutment. My abutment also will be placed at an angle to the underlying implant. So what is the angle I am introducing? What am I talking about? I'm talking about non-axial loading. I'm talking about shear stress, the tensile stress. Every time the patient bites, he is going to induce a lot of stress on the underlying implant. My bone is cancellous in the maxilla. Anyways, it does have a morphology of being somewhat weaker than the underlying cortical bone in the mandible. And I'm inducing, in fact, over-inducing the stress. Will my longevity exist? Can I proudly say that I will have long-term success? It is questionable. So what we have to understand that is, in many instances where there has been an excessive bone resorption occurring into my maxilla, even if I give a cross-bite relation of an individual tooth or two teeth, I am still giving axial loading. The patient has not come to you asking for a class 1 relation as far as canine or a molar goes. We can still give away that as far as a cross-bite relation go. But in long term, success is guaranteed because we are giving axial loading. We need not give angled abutments. We need not give a crown which is again angled to close in class 1. Few things we understand, few things will take us a long way. Coming to the occlusal materials to use, we have acrylic, we have porcelain. If patient can afford, go for porcelain. If patient can't afford, go for acrylic. Is this how we decide the occlusal material? Definitely not. We have to take so many factors into account. How much aesthetics is important? What is the impact force? What is the static load? What is the chewing efficiency? Whether the patient is a bruxer or not, that my porcelain will get fractured. Do I want my porcelain to get fractured, or do I want wear of my acrylic? What is the amount of interarch space? How much of accuracy is important as far as closure, biting, interferences, and lateral excursion is concerned? We have to think, we have to evaluate, we need to have a team to look into this, and then we have to formulate. Until we evaluate, please do not formulate. Because once you formulate, you close the doors for evaluation, and there is no looking back. You explain the patient before the treatment, it is taken as an explanation. You explain the patient after the treatment, it's taken as an excuse. We want to explain the patient. Patient shouldn't take the explanation as an excuse. Coming to the design of the weakest arch, we had Charles Darwin talking about survival of the fittest. We do not want one of the arches to die. We have to make sure that there is a symbiotic relationship, a coexistence that exists between the weakest component and the strongest component. How does that exist? We understand that in a maxillary denture and a mandibular denture, my mandibular denture tends to have a lower surface bearing area. So I have to design my prosthesis in such a way that I take care of my weakest component, which is my mandibular denture. So either I give an implant supported or an implant retained prosthesis. So I've taken care of my weakest arch. Similarly, if there's a combination syndrome, I have to take care of my weakest arch, which in that instance is my anterior maxilla. Why? Because as already mentioned in session 2 of the implant series, we do have natural teeth present. That is the lower natural anterior teeth. They tend to hit onto the palate, causing papillary hyperplasia, because of which there is supraeruption that tends to happen of my lower anteriors. There is resorption of my anterior maxilla. There is drooping down or supraeruption of my maxillary tuberosities, and then resorption of my posterior mandible. The chain reaction mentioned in session 2 of the occlusion series. We have to understand that only if we know where the problem will come, will we be ready to overcome the problem before it arrives. But for that, we need to keep our eyes and ears open. How do we keep that open? By knowing the importance of diagnosis and treatment planning. Coming to the troubleshooting and the clinical applications of this occlusal scheme for implant restorations. If it's a fully anchored bridge, we have to understand that we need to have a mutually protected occlusion. Why?